and I'm just having a quick break, so I just wanted to say I'm here, I'm at placement, and it's going well so far. It's not too bad. It's really busy, really short staffed, and we're rushed off our feet, but the time's going quick and it's all right. So let's hope the rest of the day goes okay, and I'll update you tonight when I get home what I've done today. So hi everyone, so it's 6:30, I've arrived. I'm just gonna get some tea down me and my breakfast and then get started. Let's hope today is amazing. So I've been so busy, I literally haven't had a chance to vlog after placement, because I'd finished placement, I'd come in, I'd eat my dinner, then by the time I'd eaten my dinner it was like 9, half 9 at night, and I literally just KO'd. So I haven't had the chance to just do a vlog for you all. I'm really sorry. So I'm just gonna take this opportunity now just to update you what I've done on the past couple of days on placement. So both mornings on my placement I've gone round, I've given people bowls, so if people can't physically get out of bed they have a bowl and they just get washed and dressed in bed. If they can do it themselves I leave them with the bowl, and then I come back and I check on them later, just see if they want me to do the back for them, the feet for them if they can't reach their feet. And if they need any assistance in between, I will be that person to help them. Only when needed though. We have to encourage patients and make sure that they're being as independent as possible so they can go home faster. And then the people that can't physically wash and dress themselves, I've been that person to help them do that. If you are new to the wards, if you've never been on a ward before, if you've never been on a surgical ward before, just to let you know that you are going to have to do intimate areas. You're going to have to do the bottom, you have to do the vagina, you're going to have to do the penis. If that person physically can't do it, you're going to have to help with that. So then after the personal hygiene bits in the morning, once that's been done, and sometimes actually in between that, if anyone, the breakfast comes round, so the breakfast comes round about 8 o'clock. So if there's anyone that can't physically eat themselves or they need assistance, then you will have to assist those people to eat and drink. There's different cutlery, there's different plates and things, there's different adaptations that you can put on the plates to help somebody eat. There is different sorts of cups, so with different handles. So please, if you see a patient that's really struggling to eat or drink, just get somebody to assess that patient properly and put in the right equipment that they might need, and then that'll make their life a whole lot easier. But if they genuinely can't do it themselves, you're going to have to be that person that assists them. So that's another part of my role that I've done. And then after that we go around, fill all the books, fill all the assessment tools out, do all the skin checks, make sure there's no pressure areas. Then you go around as well checking all the catheter bags, monitoring the fluid balance, because once someone's had surgery you have to have a really strict fluid balance, 24-hour fluid balance. So you have to monitor what's going in, what's going out, just to make sure that the volume inside the body is right. Because after surgery there is that risk of hemorrhaging, you could have a high volume of blood loss, you could go into hypovolemic shock, and the first thing that you're going to notice are the observations. So there's going to be a water retention because they're trying to get that volume back into the body because of the blood loss. So the urine output is going to go down because they're retaining that water to try and get it back up and get the heart pumping and get everything working again, get the blood pressure up. So it's got to be a strict fluid balance for that. But then once the 24 hours is up and it's been assessed and it's been managed and they no longer need the catheter after however long, some people have long-term catheters as well that you have to monitor, but for the short term, for the surgery, once that's out, you just have to make sure that they're not going into urine retention once it's out. You have to monitor if they've gone to the toilet, if they're using a bedpan, how much have they gone, is it a good amount, is it a small amount, if they're going regularly as well. So there's a lot of really assessments with this surgical ward. You're constantly assessing and monitoring everybody, and that's the main thing that you do on this ward. So then once you've done all of that, it's usually about 10:30, depending on what sort of day it is. Sometimes things go wrong, so you are a little bit later. So around about between 10 and 10:30, you sort of have a tea break. Our tea break's half an hour on this ward. Each ward is completely different, so if you're on a different area or a different trust, a different city to me, everyone, literally, even in the same hospital, I've been on different wards and they all run the breaks completely differently and the different times that you have for a break. So on this one it's half an hour and half an hour, so we have half an hour break around 10:30. That's what time I have mine. Between 11 and 12 I go around and do the observations, so do all the blood pressure, temperature, pulse, respiratory rate, document document it. If there's any abnormalities, I report it to my mentor. And then you want to do your documentation. You have to document every single thing you have done for that patient, from the personal hygiene, what they're eating and drinking, medications. You want to do observations, you want to do the skin check, you want to do the emotional well-being, the pain management, whether they've passed urine, whether they've had the bowels open. Literally every single thing you can think of for that patient, you have to put down in the documents, because if it wasn't documented, it did not happen. Document everything, and don't think that you're writing too much. If you're writing pages and pages and pages on that patient, I'm sorry, it's better to be safe than sorry. Document it, document it, document it. If you don't take anything away from this video, that's the one thing you have to do, is document it. So what I'm going to do now is, I've actually done like a small flashcard that I put in. Is it a flashcard? Yeah, let's call it a flashcard. So I've done a little flashcard that I've put in my pocket that I keep, that the top things that I have to document for a patient, and I'm going to show you that now, so you can either screenshot it, write it down, whatever. It just might help you organise your notes, and hopefully it'll help you out there. But I'm going to show you that now, and those little things, just they're a lifesaver, because sometimes when you've done all your personal care and everything, you sit down, you go to write your notes and you think, can't remember what I'm supposed to write, and you will have it. I've had it so many times. I'm just like, have I forgot something? Am I missing something? Because you panic, because you're thinking, I need to get everything in there. So it's sometimes it's really hard to remember what you're actually writing. But once you get into a routine and you're going and going and going, like you're so used to writing these things that you'll get into your own flow and your own way of writing things. But again, with different universities, different trusts, different mentors, you might get told something completely different. So just follow what your mentor says, basically, on what to write and what to document. And then at 12 o'clock, the lunch trolley comes round. So I help just dish out all of the lunches. And again, anyone that needs assistance with eating, I will assist with that. If anyone's got a food chart, we have to document. So if anyone's at risk of malnutrition, they go on a food chart, and it's got to be a strict food chart. You have to document what they've had to eat, the percentage or the amount that they've had to eat. So how big the bowl is, if they've had a quarter of it, if they've had half of it. You document all of that in the food chart to make sure that they're eating, they're drinking. You know, you want to assess the whole nutrition, because it's all going towards the wound healing process when they've had the surgery. So then after lunchtime, we go round and I checked all of the wound dressings. So I just assess the wound dressing. So if you can see any slough or blood or anything coming through the dressing, if it's coming away, if it's secure. I'm going to check for redness around the dressing as well, because if there's a huge red area around the dressing, you're going to want to report that, because that means there's an infection. If it's hot to touch as well, if the patient's got a temperature with it, it's all signs of infection. There was only one that I had to change, actually. And that was only because the way that someone had put the dressing on, there was a sticky bit over the staples, and I was like, I'm pretty sure that should be covered with something dry and not sticky, and not a sticky patch on the staple. So I took it upon myself to change that dressing. And I also asked the patient, I said, when was your dressing last changed? And he was like, it's never been changed since I had it done. And it'd been quite a few days. So I thought, let me change this. Let me look at the wound underneath and put a clean dressing on, so that there's no stickiness or anything touching that wound other than the padded dressing. And so yeah, so I did that, used aseptic technique. We always use aseptic technique with wounds, because you've got a risk of infection. And if you don't know what aseptic technique is, it's basically everything has to be sterile, basically. So you've got your sterile trolley that nothing dirty can touch. It's all sterile. As you open it, you don't touch anything with your hands. You open it out onto the trolley so that you're not touching anything fresh from the pack. And then once you've put your sterile gloves on, you are that clean person. So you've got sterile hands. So then once you've got your sterile hands, you can touch things on the trolley, because your hands are sterile. The trolley's sterile. But you will, if you haven't done this yet, you will be taught it at university, and they go through a whole skills session of how to do aseptic technique, so don't worry about that. So you use aseptic technique to change the dressing and clean it and make sure it's clean, put the dressing on, put the date on it so people know when you've changed it and when to look at it again. Once I've done all of my wound dressings, I go back round again. Basically every hour I make a conscious effort of every hour going round and updating the fluid balance charts, the food charts, checking all of the charts are up to date, because if they've passed urine, because it has to be like an hourly monitor. You want to make sure they're keeping hydrated, having enough nutrition. Educate them as well. It's all about educating them, because if they understand why you're doing something, they're more likely to follow your lead. Also, some of the elderly patients that I've spoke to, the minute you say, instead of pressure sores, the minute you say bed sores, just changing that language, it puts the frighteners into them. I had one lady and I was like, pressure sores, and she's like, what? And I was like, you know, like bed sores. And she's like, oh, bed sores, never. I can't get any bed sores, can I? I was like, and she literally, just that slight terminology, just literally, she's like, okay, I'm gonna move. So literally then, I think every hour she was on it. She was like, I'm gonna have to move, I don't want a bed sore. She was on it. It's not funny, I'm laughing, but it's nice to see that if you just use that just slight different terminology with some patients, that they actually do listen to you and they think, okay, I need to do this and I need to listen. So my piece of advice is educate your patients on everything you're doing and why you're doing it. And that's the important thing, why we have the theory at university, because we need the knowledge to educate our patients so they can understand why we do everything that we do. And then secondly, use a terminology that your patient is going to understand. Different patients have different levels. One day you might be nursing someone that's an actual nurse or doctor and they understand all of the terminology that you're telling them. And not only that, some of them want the terminology. Some of them are like, oh, and they'll reel off all these words. Some words I don't even understand, and I'm like, okay, just explain that to me, please. And it's just amazing to see how different people are. So you have to just assess each person as an individual and how you're going to approach that person, how you're going to educate that person, and what terminology you are going to use to get your information across to a patient. It's really, really interesting. It's one of my favourite things I do in nursing, I think, is that I love it. I love how different people are. And yeah, that's all I'm going to say about that, because I'm rabbiting on for absolutely forever. It's 4 minutes now, so I'm going to just end that one on there. And then we had a few patients go home. So we had, I think, 3 patients, possibly even, was it 4? We had 4 patients all go home on the same day. So we were discharging all these patients, and then you have new patients come in, so you have to do all of the risk assessments and everything again, and it's just like this cycle. Any post-op procedure patients, so any patients that's come straight from theatre to you, if anyone's already on your ward but they've gone to theatre and then they're coming back because they've just had surgery, you're going to have to be really thorough with the observations. So the observations you have to do for 2 hours, you have to do it every 30 minutes, so 4 lots of 30 minutes. Does that make sense? So 30 minutes, 30 minutes, 30 minutes for 2 hours. And then you want 4 lots of hourly obs, so every hour for 4 hours. And then after you've done that, it's every 2 hours for 8 hours. So you want, basically it's 4 lots. You just remember the 4s. So 4 lots of 30 minutes, 4 lots of 1 hours, and 4 lots of 2 hours. Does that make sense? I hope that makes sense. If not, I'm going to put the little, here, let me show you this. This is what they need post-op, basically. So you've got 4 lots of 30 minutes obs, 4 lots, it's 4 lots of hourly after the 30 minutes, and then 4 lots of 2 hourly obs. But that's what you need, basically. And you go through all of this checklist. That's what you're going to do. Got a few flashcards made. I've got this one. I've got post-op procedure. I've got documentation. I've got the discharge. I've got admissions. So those are all of my little flashcards that really helps me when I'm out on the wards. So don't need to keep asking people. I've got it there. I can just have a quick glance and then get on with it. So yeah, it really helps. And then in between everything else, you are answering the call bells. The call bell will go off all of the time. People want their jug filling up. People want to know updates about the surgery. They want to know when they're going down to theatre. They want to know when the relatives are coming. They want to know if you can ring their relatives. They want to get you to sort out their TVs. They want assistance with their bags and things. They want the toilet. They might have been sick. The bandage might have come off. The wound dressing might have come off. They do buzz a lot, so you'll be getting the buzzers going off as well as trying to do everything in between. The phone will be ringing, so there'll be relatives calling you, there'll be other wards calling you, the bed manager will be calling you. You've got so many things going on. You are literally just here, there and everywhere when you're out there on placement. And then by the time you come to 5 o'clock, you've got the dinner time coming round, so you've got more food coming round. And then once all the dinners are out, I go round and I do the medications with my mentor. So as a student nurse, you have to be supervised by your mentor to give you medications. I think I said this in my last vlog. So my mentor supervises everything I do, and she asks me questions as I'm going round as well. And actually, something really funny, you know, I had some of you might know, some of you might not know. So some of you that have watched my maths calculations vlog and my drugs calculations maths exam that I had on, what day was it, Wednesday, Thursday? No, it was Thursday, on Thursday. So we had a very interesting patient that had a penicillin allergy, and this patient he needed penicillin basically. I don't want to go into too much details because patient confidentiality and things like that, but the patient needed penicillin. And so they have to bring in the allergy nurse who assesses the risk of, okay, is the infection going to be worse than the reaction of the penicillin that he's already had? Does that make sense? So this patient, his allergic reaction when he had it when he was younger, he had a rash. So he didn't go into anaphylactic shock, it was just a rash. Even though it's an allergy, it's not the worst type of reaction that he's had to penicillin. So the risk that he's got at the minute outweighs the risk of just having a rash. And okay, a rash might be really devastating to some people, but the fact that if he doesn't have the penicillin and the infection doesn't resolve, he could potentially pass away, resulting in death. I think give it a go with the penicillin is what they were saying. So basically, this allergy nurse came and she said, okay, so to do this, what you have to do when someone has a penicillin allergy or any allergy to any drugs, they give it bit by bit at different stages, and in between you giving it, you have to do all of their observations to make sure they're not having a reaction. So what we did was we gave so much of the drug, and then half an hour later I did all the observations. Observations were fine, so you could give just a higher level, just a slightly higher level dose of the drug. Do it again half an hour later, do all the observations. If the patient's okay, you give it the double the dose, and again do all the observations half an hour later. Patient's okay, patient's cured, he's all right on penicillin, so we can now treat him with penicillin. Basically, I hope that makes sense. I hope it makes sense. What was I even saying? I wasn't even going on about this. I'm really sorry. That was a really interesting case and I've just gone off topic about drugs calculations. But anyway, I was in the room, in the drugs room with my mentor and the allergy nurse, and they're like, let's test Claire, the student nurse, on her drugs calculations. I was like, oh my God, why? Why would you do this to me? I'm tired, I'm not ready for this. And what was the question? I can't even remember the question. There was 250 grams in 5 millilitres. He only needs 50 grams. How much of the drug in millilitres does he need as an initial dose? And I was there like, my brain went blank, and I was like, I know this, I'm really good at drugs calculations, I've just got 100% on my maths exam, come on. And I said, can I just write this down on a paper because it's really baffling me right now? And then I was like, okay, 250. How many 50s are in that? And then I went on and on. I went a really long way about it anyway. And then I was like, 1 mil. And they're like, yes, 1 mil. So we gave him 1 mil of penicillin to start with. And then we increased it to 150 milligrams. So then she was like, questioned me again. Okay, so we've got 250 milligrams. You only need 150 milligrams. How many millilitres are you going to give? And I was like, wait, okay, so there's 50 milligrams in 1 mil. So we need 3, because then 350 50s is 150. So I was like, 3 mils, and they're like, yeah, well done. And I was like, yes, I've got this, I've nailed it, my patient's going to survive this. And then they were like, okay, so now you need 300 milligrams. How many millilitres you need? I was like, well, we've already got 150, so we'll just double it because it's 300, so we need 6 mils. And they're like, yeah, that's it, yes. Come on. I was all right with my drugs calculations on the day. To start with, I did need a paper and pen because sometimes I just need to write it down and see it than hearing it. But you know where your brain just goes and someone fires a question at you that you're not expecting. I was just there like, oh, I'm just a student, leave me alone, come on. So the drugs round went well. I got tested on my drugs knowledge and I was all right. I did good, to be fair. And then she gave me, oh my God, so I'm sure it's the same in most universities. I don't know what every university does and how they work the drugs, but with our university and a few people from other universities that I've spoke to, you have to get tested on your drugs knowledge, because obviously we're given medications as nurses, so we need to be on the ball with our medications and know what we're giving a patient and why it's given. So for our university in year 2, we're given 10 medications that we have to learn. We need to learn the side effects, the dose, the contraindications, the precautions, all of that. What the drug's for, so the uses, because different drugs do different things, and they test you on 10 different drugs. So my mentor gave me 10 drugs to revise, and on the last 2 she put 2 down, but on the last 2 I've noticed she's just put on the side, what is the reason we would give these particular drugs to patients? And I've looked at them. One of them's vitamin B and C, I think, and the other one's thiamine. Is it? Let me check this. Yes, so vitamin B and C and thiamine. This is what she's put. But yeah, she put, why do we use them? So I'm just gonna hazard a guess without doing, I haven't done my research on this yet. I've literally just got them out since she's given them to me. So my guess would be vitamin B and C is to do with, it's all got to be to do with wound healing. Thiamine, oh, I'm assuming that's the same. What does thiamine do? I am going to research this, but my guess with vitamin B and C is it's all to do with the immune system, so boosting the immune system, because you need that for the wound healing. Thiamine, I've got a feeling that thiamine's to do with blood and thiamine. Thing is, I know the name and I know it, so I'm thinking, I know it, but what? It's just picking your brain and trying to throw it out there. Thiamine. But B and C is definitely, it's got to be for the immune system and boosting the immune system and just to help with the wound healing process. And I'm assuming that's what thiamine's for as well. But I'm thinking thiamine's got to be something to do with more blood related, but I'm not sure what. But I will let you know when I find out, because I'm going to Google it. Shall I Google it now? Let me Google it now and I'm going to get back to you. Okay, I'm back. So, just having a quick glance at Google, not that we should ever Google things. Thiamine is used for a couple of things. So it can be used for heart failure because it regulates the heart, but it helps with memory and brain function. But I think one of the main things, I'm gonna guess, with the surgery and wound healing process for thiamine for this particular ward, I'm guessing that thiamine is used because it breaks down and processes carbohydrates, fats and proteins, and the body needs those things to make ATP in the body, so you need the energy basically. It helps that, so you need ATP for your cells to work and function, and for your immune system to be good, for your heart to be functioning, for organs and everything to function properly. You need that energy to keep going and keep processing and get that wound healing on the move, keep that wound healing on the move and everything. Does that make sense? That's what I get from Google. I literally took 5 minutes having a look, so I will look into it a lot more and hopefully have a proper answer for my mentor. So then to end my shift, once I've done all the medications, I go around again, check all of my patients, make sure they're drinking, make sure the food diaries have all filled out, make sure all of the catheter bags are draining properly, make sure there's no blood in the catheter bags, make sure they don't need emptying. If anyone needs the toilet, take them to the toilet. Just doing that last check before I leave, and then updating my mentor if there's any problems or anything, because she will do the handover, and sometimes you will do the handover. I have done a handover before. I haven't done one recently, to be honest. Yeah, sometimes you'll be that person that gives the handover to the night staff, so you need to tell them any important information about your patients and just all of their back history, what they've had done, what's expected, what the plan is for them, all of that jazz, so that they know what to do in the night and what to monitor a little bit more closely sometimes, if you need to monitor a patient a little bit more closely. And then I go home. And that's it. So yes, when you get home, it is lovely. I do love coming home and putting my feet up after a long day. It's 12.5 hours, and it goes fast, but it is a long day. And you just, when you get home and you put your feet up, honestly, there is no feeling like it. It's just, yeah, it's really nice to put your feet up and just be like, that's it. And then my alarm goes off and then I have to do it all over again. Good job, I love being a nurse, isn't it? So yes, the wards are busy, they are manic, they are crazy, but overall I love nursing and I love patient care and I love assessments and I love wounds. You all know I love wounds, so I love doing the dressings. And I hope this is helping people. If you've not been on a ward before, if you don't know anything about orthopaedics or surgery patients, anything like that, I hope it's helping you a little bit, to give you a little bit more insight of what you're going to be doing out there in the ward. But as always, if you've got any questions, please feel free to ask me, because I've probably forgot half the things that we do in this vlog and I'll probably have to do another vlog. But just ask me if you need anything. I'm always about, I'll always reply to your messages, even if it takes me a little bit longer sometimes because I'm on placement or I'm working. So yeah, just let me know. And as always, thank you so much for watching. And that's it really. I've not got much else to say. I think I've talked way too much in this video. As always, I'm really sorry if you're bored by the end of it. But I hope that it helps someone out there, because that's why I do this. I hope that it helps give a bit more of an insight and get you really passionate and motivated about nursing. So I'm going to stop talking now. I'll see you all later. Have a great day, have a great week, and yeah, see you next week.